now entering the Pain Pod, sponsored by the Chronic Pain Association of Canada. Are you ready to know what you don't know about chronic pain? We're shining a light on the good, the bad, and the very ugly about living with pain in Canada. No hype, no hysteria, just the truth. And now, here's your host, Ann Marie Gaudon.
Good afternoon, Pain Potters. It's nice to be back again. We're in the middle of summer here in Southern Ontario. Nice, warm sunshine, if that's your kind of thing, which for most people it is. So I hope you're all enjoying that as much as you can. We've got another great guest for you here today. Let me introduce her. Leigha Comer is a critical sociologist at McMaster University, that's here in Ontario, specializing in the sociology of health, drug policy, and chronic pain. That's a lot. She is a Social Sciences and Humanities Research Council of Canada, or SSHRC, postdoctoral fellow, and has contributed to various academic publications, including a recent piece in the International Journal of Drug Policy. Leigha Comer's research focuses on the barriers to accessing opioids for pain management, and she's been recognized for her significant impact on the field. She has also written a book entitled No Hope for Relief that the University of Toronto Press hopes to publish by the spring of 2027. Welcome so much. I'm so happy that you're spending some time with us this afternoon. Welcome, Leigha.
Thank you, Ann Marie. Thank you so much. It's so nice to see you.
Oh, yes, I agree. So, Leigha, let me start by asking, what is it that even led you down this path of research? Because I don't think I personally know another researcher in this field other than yourself. How did you get here?
Absolutely. How did I get here? How did it start?
How did you even start into this field? Yes.
Absolutely. A lot of it had to do with my own experiences of chronic pain. And so this would have been back in about 2013. I was about 21 at the time, 2021, and I started developing what I eventually found out would be chronic pain. At the time, I didn't really know there was such a thing, and I kept going to the campus doctor. I was in university at the time in my undergrad, and I just thought they're going to find out what's wrong. It's just taking a little bit of time. And I remember very clearly being in the doctor's office, and she had written something, they write on the notebook. And so she left the room to go get a requisition form. And I felt guilty doing it, but I figured it's notes about me. So I kind of leaned over just to see, and I saw that she wrote chronic pain and circled it. And it felt like I had been like physically slapped, honestly. Not that she had done anything wrong, but that word chronic, I'm trying to figure out, okay, so is that meaning there's no cure? We don't know what it is. Does that mean I was 21 at the time? So I'm thinking I got a bit ways to go. Is this the rest of my life? Right? So, not the best situation. And so what I ended up doing is joining a lot of in-person and virtual support groups for people with chronic pain. And then that's how I sort of got into this field of research, because by the time I had that diagnosis, I was starting my master's degree at York. Then I went on to do my PhD. And so a lot of what I researched, and so as you said, I researched things like opioid use, chronic pain. Those were things that I was going through, and also I was seeing as big problems in my groups, but also we were connected to other groups in Canada. I mean, there's huge Facebook groups, right? And so, for example, when I started my PhD, I was noticing a lot of people talking about not having access to opioids. They'd been on them for 10, 20 years and suddenly couldn't access them. And so that's how I focused my PhD, and that's the subject of my book. Opioid use disorder came up because it was recurring in those interviews increasingly, both with physicians and with patients. A lot of them saying, oh, I just got diagnosed with opioid use disorder. I don't know if you know what that is, but I saw it on my chart. Or doctors telling me, I've been, increasingly, there's an increase in diagnoses that I'm seeing in my practice. And so I didn't have the time in my PhD to look at that, pinned it, and said, I'm going to come back. And so that's what I'm doing right now. So that's sort of how I got to that track of opioid use disorder.
Okay. I'm sad to know that's the reason that began for you, but I understand how you felt, because if you don't have chronic pain, in your mind, you have something, you go to the doctor, they fix it, and you're done.
Mm-hmm.
And when that doesn't happen, a whole other world opens up. So, sorry, I just hit a window, I think. There we go. Okay, so Can you define this opioid use disorder for our listeners? Like, what is this?
Absolutely. I think the definition itself is very interesting because it comes from this text called the DSM-5. So that's the Diagnostic Statistic Manual. It's from the American Psychiatric Association, and we're on a revised version of edition 5. What it is essentially, it's a text that standardizes diagnosis of mental disorders, right? Or mental conditions. And so it has the definition and then it has the criteria. The idea then is that any clinician looking to diagnose or also researchers looking to study are going to have these standardized criteria. So there's been an interesting shift where previous iterations of the DSM would have said, use words like addiction or substance use. The DSM-5 is the one that said, okay, now we're going by the substance one is addicted to. So opioid use disorder is specifically for opioids, an addiction to opioids. And the way I think it's 11 criteria, and people have to meet at least 2 to meet the criteria to be diagnosed. So, right. So it's a low threshold. It's a low threshold. And so what it is defined as is problematic opioid use, a pattern of problematic opioid use that affects one's life. That is the overarching definition. And then that raises for me, and the reason I got very interested in the diagnosis is that raises for me a lot of questions about problematic to whom or for whom, right? So this idea of disordered is very vague to me. And then when I look at the criteria, there's 11 of them and there's a checklist. A lot of them are things that a lot of people who use opioids, including people with chronic pain, are going to meet, right? And so, for example, one of them would be spending a lot of time seeking opioids is the terms that they would use. But I know from prior research I've done that, yes, people with chronic pain often do spend a lot of time trying to make sure they have their opioids, their medication, because it takes a lot of work, especially as we've seen people have less and less access to opioids now. Doctors are more reticent to prescribe. So absolutely, you are calling your pharmacist to make sure your prescription's available for pickup, especially before the holidays or if you know they're going to be closed. Of course, you're worried if your doctor's,
Panic. Yeah. It's like,
right, it's a huge panic.
It would be like your insulin. Like, what am I going to do? Like, I can't.
Exactly. So, of course, everybody, usually if you have a medication that's important for your health or your quality of life, you're making sure that you have access, right? The same thing if your doctor says, I'm going to start tapering you, or you can see that's the direction it's headed, and you've heard other friends have that experience. Of course, you're going to start looking for another physician and start asking, is your doctor a bit more flexible, or have they gotten reprimanded by their college? Within the criteria that can easily be seen as disrupting your daily life, spending too much time on opioids, right?
And so they can just subjectively decide what too much time is?
Yes. So there's certainly a subjective element to it, right? And then another criteria would be physiological changes such as like tolerance or withdrawal, where we know that anybody, if you're using opioids for an amount of time, you are going to build a tolerance. That's physiologically what happens. And yes, you're absolutely going to have withdrawal when you come off, especially abruptly, right? Even if you taper, you're going to likely have withdrawal symptoms.
A lot of other medications as well, not just opioids.
Yeah. Absolutely. And so this is where my interest came, because when I was interviewing doctors, they would say to me, oh, it's actually very easy to diagnose somebody with opioid use disorder. It's the easiest diagnosis, right? Because it's just 2 out of 11. And if you have somebody who's using opioids, there's a good chance they're going to hit some of those criteria somewhere. So yeah, so there's quite a low threshold. And so we see then this increase of people with chronic pain being diagnosed. And my other concern being they don't always know that it's happening.
The patient?
Yeah. So a lot of the folks I've interviewed for this project, they found out that they had a diagnosis in unexpected ways. So for example, there was an Indigenous woman in Ontario who went to the emergency department, and she had broken something. She I think it was a leg or something like that. So she was in the emergency department. And then that's when it came out that she had a red flag on her medical chart because everything's electronic and said, no, you have an opioid use disorder diagnosis from the last time you were in the ER because the doctor saw that you use opioids. And so no pain medicine for you. You can have a Tylenol, right? So that's a huge shock. And that's how a lot of people find out. They get their chart or they start noticing something is off. Why was I referred to an addiction clinic? And then they go and check their chart, and then that's where they find out.
Speaking of shock, people die of the shock from pain if it's not treated properly.
Absolutely.
Oh my goodness, broken leg and take a Tylenol. Okay. How was the research for this new diagnosis conducted? Like, how does a study of people in their environment work in this way for you?
So I do something called institutional ethnography. Really what that means is that I am finding people involved in this larger structure of what I would see as opioid use disorder. So I'm interested in all the way at the start who created the diagnosis. And so I'm interviewing the folks, the researchers, the clinicians who were involved in creating the diagnosis in the DSM-5. And then I'm interested in, okay, well then how is this diagnosis being translated into clinical practice? Meaning how are physicians actually diagnosing? And so I'm interviewing physicians, whether they're practicing in hospital or they have their own private practice or in an addiction treatment center potentially to figure out when do you diagnose, what are you looking for, things like that. And then I'm also interviewing people with chronic pain themselves. And there's an interesting mix. So there's some folks for whom they do feel that opioid use disorder was appropriate as a diagnosis and they felt that it's improved their life. And then there are others for whom they didn't know, they were shocked, they don't feel it has any applicability to their life whatsoever. Or this is an interesting one where they knew it was being diagnosed, but it was strategic on behalf of the doctor. So what I mean by that, for example, is if they want to use, the doctor won't prescribe opioids anymore for chronic pain because they've been told by their college, you're prescribing too many opioids. They say to the patient, I could give you Suboxone or methadone, but it's not going to be covered by your provincial benefits plan because they're on that type of benefits. They're low income usually. So if I diagnose you though with opioid use disorder, it'll be covered, right? So it won't be covered under a provincial benefits plan for chronic pain, but I can get it to you covered for opioid use disorder. So then there's that tension of this is like a double-edged sword for me, but I need the pain relief. Let's go for it. So they're very aware of that. But would they identify as, yes, this is valid for me? No.
Right, and up against a wall. Oh my gosh. So do you know like what types of credentials of people actually did the invention, the creation of the definition?
So it's interesting. It was a group of international researchers. And so from my recollection, the folks I've interviewed, they are academics, right? So these could be folks who have expertise in addiction science, particularly. And usually the idea is to figure who is the expert in a couple of countries and then bring them together. And so they are looking at all of the research out there, and then they are determining what criteria are we going to use to figure out this diagnosis. But there are, of course, other factors that go into their decision making when they decide what is the diagnosis and who really meets the criteria. What are the criteria? And so that's really what was interesting about my interviews with the researchers, because I went in and asked very broadly, tell me how you come up with these criteria. And they would say, yes, of course, we look at the literature, we look at studies, things like that. But for example, we have to think about insurance companies, right? Because this is an American Psychiatric Association. They're in an American context. And so they're thinking, if we make the criteria so broad that then lots and lots of people have opioid use disorder, insurance criteria or insurance companies are not going to like that because now they have to cover more people. If we narrow it too much, now there's not that population, that patient population. So they run statistical simulations on the computer to say, if we add this criteria, how many more patients are added or removed? And there's that playing around with it. Yeah.
So were there no like proper I mean, high, top of their game, proper pain doctors included in this that do not treat addictions, just the pain system and no.
Pain doctors, no. I couldn't say for sure, like I would have to look, but that's the other thing is that addiction medicine and pain medicine have been so, at times they come together and then at times they don't. And I don't always think they come together for the best of the patient, to be honest. I think they come together when it comes to surveillance, panicking about what they call opioid related harms, things like that. So it was largely from an addiction medicine lens, from my understanding.
Okay. All right. So, my goodness. Okay, medicalization. What is this process and how did this unfold in your research?
Right. So medicalization is the process through which human experiences, lives, the things that we go through come to be seen as a medical problem, usually. They become what we call pathologized, meaning it is not pathological, meaning abnormal, right? There's something not normal about this. And so there's been fantastic research done by sociologists on the medicalization of, for example, menopause, women's changes, hormonal changes, things like that. And I think what's important is that a look at medicalization is not saying it's bad, right? For a lot of people, that's been very important. For a lot of women going through, or anybody going through menopause, that is really important to have that medicalized and to get access to treatment. For a sociologist, the interest is in, okay, well then what are the implications? What happens? Why did it happen? How does it happen? What are the implications? It could be good or bad. It could be somewhere in between. And so when I look at the medicalization of opioid use, that's what I'm looking at. Humans have used, non-human animals have used drugs for millennia, right? And so when we look at this framing of the use of something as medical and it comes to be seen as a problem, that's a process of medicalization. And so this decision, and that's how a diagnosis becomes created, is through medicalization. And diagnoses are not always bad, but it is a particular way of framing a situation. It would be, for example, um, well, this has changed actually. I was going to say that usually caffeine use is not medicalized. In fact, it is. There is a caffeine addiction in the DSM-5, right? And so these things change over time. Yeah, and now there's behavioral addictions that are being medicalized. And so the one that I know of is gambling disorder is in the DSM-5, and then there are others that are sort of being left open right now. So internet addiction, there's also food addiction, right? And so these are highly contested. And so you're taking these things and saying, actually, this is a medical problem. It's abnormal. It's not within the norm. And so that raises for me, again, as we were saying earlier, these questions of, but according to whom? If you are taking a medication because it relieves your pain, I don't know that that's disordered. I think there's tension there.
Would this, what we're talking about here, be not necessarily like a physical medicalization, but a psychiatric medicalization?
Mm-hmm.
That even makes sense? Am I?
Mm-hmm.
That's how I feel.
Absolutely.
Yeah.
Absolutely. There's a psychiatric medicalization occurring, and we see that all the time, right? And so there's been the provenance. And again, I'm being very careful here. I'm not saying that these do or don't exist. That's not my interest whatsoever. That's not my expertise. That's not my field. But the question is then, what becomes of it, right? So, for example, I have two young boys who never sit down. They're 6 and 8. They never sit. We've been told, well, I've had one person come to our home, look at them run around and say they have ADHD. You got to go in and get them fixed for that. Now, I'm not saying that ADHD absolutely is a thing. And for a lot of families that helps, but it's a particular framing. And then that's going to then bring up new possibilities, new changes, as opposed to my framing, which is just, they're like my husband, who also can't sit still. It's just what they are, right? It's just how they are. And so I get them to run. I just get them to run and get all that energy. And neither is good or bad, but it's a different framing. And so if collectively, medical, public, everybody's starting to see opioid use as a medical problem, well, that has implications for people who use opioids, right?
And the implications for real people are.
Mm-hmm. I would say one of the big implications is that once you have that label of opioid use disorder, it it haunts you is the language I would use. It haunts you everywhere you go, especially because now everything is so integrated with electronic medical records, right? And so the people I interview essentially say I'm doomed, right? And even I've had somebody I interviewed who was in the Northwest Territories, moved to Ontario thinking they could get away. They're not trying to hide anything. They're just thinking, okay, well, I don't think this was a correct diagnosis. I'm going to come here. But no, it's all increasingly national. And so it follows. And then they still come here. They go to an emergency department. Eventually, we're diagnosed with lupus many years later. But at the time, it wasn't diagnosed. We're in crisis and in a lot of pain. And we're told, well, you have OUD. Some doctor put on here the last time when someday in the Northwest Territories you went in, they saw you have opioids. You don't know it, but they wrote on here OUD. She wasn't aware, and it followed you here. So the doctor finally, somebody told her that's why.
And that's going to follow you forever. No one's going to take that off.
Yes. No, they're not. So one thing some people are trying to do is help patients clean their medical charts, but that's really tough. It's hard to get it completely removed. The most you could do probably is add some sort of addendum or note saying it's not agreed to by the patient challenges. But the reality is if you're a doctor and you get a referral and you see OUD and then the little note saying the patient contests it, there's a stigma there, right? Of, oh, well, of course they're going to contest it. You're not going to take those on equal levels, I don't think.
I don't think so either. I think you're more apt to believe your colleague.
Mm-hmm.
That's right, but maybe you're more apt to believe your colleague than you are the patient.
Mm-hmm.
Oh
Mm-hmm.
my goodness, this is just getting uglier by the moment. So can you explain the gray area of the notion disordered opioid use and how it affects patients? Is that something different?
It is, I think, because I think that this idea of language is so interesting because originally it was this terminology of addiction. And then different versions of the DSM said, okay, well, now we're going to use substance use disorder, meaning something is disordered, something is not orderly and correct, right? There's not a nice orderly pattern. There's some disorder here. And then now we have opioid use disorder. And I just struggle to pin down, and this is where I'm at now in the research, what is disordered exactly? Because it's a very individual level. There's something wrong with that person. Where I'm seeing very structurally, the disorder is largely being introduced because people are being rapidly taken off their medication. Doctors fire people with chronic pain. They don't want them as patients. They don't take them as patients.
They don't.
Right? We know that, for example, in smaller communities, there's not a lot of family doctors. And so it's locums who come once a month and say, I'm not going to give you opioids. I don't have any relationship with you. So, right, that's a lot of disorder. We know that how many people I've interviewed where they go to the pharmacy and then suddenly your doctor cut you off. So that was your last refill. So good luck for you, right? So that to me is highly disordered is the system, but I think it's all being concentrated on the individual being seen as disordered. And I really struggle with that classification, if I'll be honest, like that depiction of people.
So is that a separate thing in the DSM?
No, it would be under opioid use disorder. And my understanding, the way I read it, and from what I understood of the interviews of researchers who designed the diagnosis, was essentially, okay, their use is disordered and problematic. How do we understand disordered and problematic? And I just, from actually talking to people, the things that are being seen that they're doing as disordered and problematic, I see as actually very rational. If I'm in a lot of pain and I'm scared that 2 weeks of holidays are coming up, yes, I'm calling my pharmacy every single day saying, where's my prescription? I'm traveling for a month. Where's my prescription? I don't think that's pathological. I don't think that's bizarre. I think that's quite rational, appropriate behavior. Yeah.
Well, it's just trying to be prepared so that you can manage wherever the heck you're going, right? So you have what you need where you go, as if it were any other kind of medication. Oh my goodness. So out of everything you're telling me, which is fascinating and I have to say sickening at the same time, no pun intended, but it hurts my heart. So a diagnosis now we have shaped by cultural, social, political, and institutional factors, including institutional agendas. And when you put the insurance companies in there. They have a say too.
Mm-hmm.
And interpersonal dynamics does not sound very medical to me. It sounds like putting a patient on a one-way road to a rehab treatment center. Is this happening?
Mm-hmm. It is. And I think what's interesting too is that what you're saying is such an interesting point about how medicine itself is a culture, right? And so sometimes medicine very much sees itself as we are neutral. Everything we do is neutral. It's objective. It's away from the world, and that is not true. Medicine changes its mind all the time, right? So we saw in the 90s, for example, pain was a fifth vital sign and you should be aggressively treating pain, right? And then we swung the pendulum to the other way of you don't give, I mean, there's sometimes not pain management appropriately given for cancer or surgery, right? Like quite serious implications. So medicine is constantly switching its mind. It's its own culture. And so that's, I think, one of the key things for me in doing this research was seeing if they are saying that this is a medical process of making these diagnoses and that they are getting closer and closer with each edition to coming to some truth that will be applicable to everybody, and it's more true and it's more evidence informed, that's not what I see personally as a sociologist. I see paradigms changing and people's ideas changing. And I don't think we're getting any closer to a truth or a better. I think we're trying to grapple with something that's really complicated. Because you bring up addiction treatment centers, right? And so I've interviewed the CEOs of certain addiction treatment centers, and a lot of them do offer a viable path for people with chronic pain who have nowhere else to go for their pain medication. And some of them, the people I do interview, are quite honest with me about, you know what, Leigha, I actually do think it was affecting my life in a bad way. I know that's not what I'm supposed to say, but the truth is, Leigha, I'm going to be honest with you, it actually was not good for me to be on that high level. Fair, right? Absolutely fair. They got the care they needed. But it's a lack of possibilities and choices. And then unfortunately, I don't like this, but the truth is that addiction and addiction treatment are so stigmatized in our society. It is such a scarlet letter. It is very stigmatized, even if you go into a doctor's office and they see on your referral that you've been treated at an addiction treatment center. It's you're here for opioids, you're here for drugs, you're drug seeking. And I think that's horrible, but that's the reality of the structures that we live in. And so it's
Yeah,
very
I think say
dangerous.
like 90s and before, I was treated like a patient, like I'm assuming
Mm-hmm.
like the other patients. Now I'm the scarlet letter.
Mm-hmm.
And
Mm-hmm.
I haven't done,
Absolutely.
I've done nothing. Like it's just the way well, not the winds. I'm sure there are people behind this. I don't know the whole story, but I mean, there was
Mm-hmm.
a time when, like you said, it was the fifth vital signal, and you treat it aggressively and you do what you can. And now the pendulum
Mm-hmm.
is swing way too far in the other direction. So are there people that are more at risk for getting on this one-way road to the treatment center?
Absolutely. Absolutely. There are so many inequities that are already baked into our society and the medical system. And so I see it come up. Like when I interview Indigenous people, huge concern because they are already so stigmatized and associated with addiction and drug use. That is such a catastrophic situation for them to be in. Anybody who has a history that they've revealed, they've confided in the doctor about, I had a history of substance use, or anything that starts to trigger for them, this person's a risk
Or
because
my
they have
family has a history. Not even me. My
exactly
family
my
has a history.
family.
Yeah.
There are checklists of, for example, the adverse childhood events checklist, right? And so, have you ever had a history of being abused sexually? Was there violence in the home? Things that you did not choose that were done to you. However, if you disclose or you're asked to fill that out, you're seen as high risk. So, if you're using opioids and then now you have this history that you very bravely confided, you are very much going to be tunneled in that way, from what I have seen and heard. Absolutely. Women are more at risk,
Well,
I
I
would
was going
say.
to say that women, Indigenous people, women, probably people of any
Hmm.
color, really. Um,
Absolutely. Absolutely. If you're somebody who is unhoused or ever been unhoused or precariously housed, I had a doctor who said, if I talk to someone, and this is his language, not mine, if I talk to somebody and he says he's not an addict, but he's homeless and goes to the Salvation Army, I know he's full of beep, right? Yeah. So no opioids for him. Yeah. Yeah, even though we know unhoused people are at such a vulnerable population, at such a risk of medical complications and chronic pain, it is a huge crisis in that population. But I know then automatically they're not getting anything, right? They're an addict. I'm going to see them as an addict. It's going in their chart. That's not a formal diagnostic process. It's not, right? It's just not.
No, oh my gosh. Okay, so yeah, so a lot of those populations are marginalized for many, many things. And this is one more thing that they don't need, that they have. Okay.
Absolutely.
So finally, I want to ask, is there any way that a patient can sort of save themselves from getting this diagnosis to begin with?
I think there is, and I would have two thoughts about this. The first is that sort of self-advocacy, right? And now, of course, when I'm saying this, I'm separating the folks who do feel that diagnosis is valid for them, which I think is fantastic. And I hope that they can continue with that and get the treatment that they need. Now, if somebody genuinely is starting to feel like there's something not quite right here, like why was I referred to the addiction center? Yeah. Why, as soon as I go in, do they ask, are you here for opioids, right? Absolutely, I would check your medical chart. I would ask for it. It depends on your jurisdiction, but certainly you could ask the hospital for your medical chart, and I would look through that quite closely to see what's there. If there is a notation of opioid use disorder, there are advocacy groups I know are out there in Canada, depending on your province, but that is an uphill battle to get that challenged or removed. Certainly, you could reach out to the licensing college in your province, express why you have a concern, and see what can be done. The other thing is, if you are in a situation where you are being told or the conversation is veering toward opioid use disorder, I'd be quite firm and ask, I just want to understand, are you undergoing a formal diagnostic process right now? Can you explain to me where these judgments and where I fit in the criteria? Could we have a conversation about that? So I'd be quite strong about that and letting them know that I know, right? I know what's happening and I have some concerns here. And so I need to know, I deserve the transparency. It's about transparency and accountability, right? Those are ways I think that you could advocate for yourself. Absolutely. It just saddens me to say that because I think these are all useful tools. I just wish it didn't fall on the individual again. I wish that there was, and this is what I hope to do, but more collective changes so that it's not always on the individual. Every time you go into the doctor's office, it's, here we go. And I got to fight for my life, right? Because we all do. As people with chronic pain, you go into the doctor's office.
I know. And then you're just kind of like in fear that your prescription is going to go through or not, or whatever. Like, it's just like, when did going to the doctor become so fearful? And when did all of these other players, like the politicians, the insurance companies and everybody, get into my medical appointment? You know, it's
absolutely,
it never used to be.
It's such a tough, no, it's very difficult. It's what we would call impression management. And so when I'm in there and even on my way to the appointment, I'm thinking, okay, especially as a young woman, they are going to be looking at me. They don't take me seriously. Okay. So I got to be thinking, I need to show them I'm in enough pain that my pain is taken seriously, but I need to make sure I'm not quote unquote emotional about it or upset, because I've interviewed doctors who have said, if you don't have a good sense of humor and you're not relaxed and you're crying about your pain, forget it. You're histrionic. You're not getting an opioid. Right. But then if I act like that, they're like, I've had doctors say to me, well, you can't be in that much pain. You're smiling, laughing. Well, I'm trying to make you comfortable because otherwise you're going to say she's an emotional woman. Get her out of here. Right. So it's hard to play it, know what to do.
Yeah. And you can't be your authentic self in pain. You have to put on a mask of some sort just to be at the mercy of trying to get pain relief.
Absolutely. For sure. Yeah.
Oh my gosh. Well, thank you so much. I know you're so busy. Thank you so much for coming on to discuss this very important conversation. And I know you're busy, and it's hard to get a hold of you. That's what I'm saying. I appreciate you so much. I really hope to see you again before we finish up. We have a few more pain pods to go, and then that'll be the end of it. But hopefully, I've got my fingers crossed that we'll see you again. And take care and enjoy your little ones running around. Because one day they won't be there running around, and you'll be missing that too.
Absolutely. No, that's fantastic. Thank you such, Ann Marie. It's always a pleasure.
Oh, enjoy your summer. Take care. Okay.
Okay. Bye.
Bye.
Thanks for tuning in to the Pain Pod. If you enjoyed this episode, be sure to subscribe so you never miss a future show. Share this with your friends, and if you're so inclined, give us that 5-star review and comment. We hope these podcasts motivate you to get involved with us at chronicpaincanada.com. Until next time.